Good morning. I'm Dr. Ala Musbah, Professor of Obstetrics and Gynecology, Faculty of Medicine, Mansoura University. My title today is Pelvic Inflammatory Disease. So, what I wanted to discuss with you, the definition and the prevalence of PID, pathogenesis of PID, clinical manifestations, diagnosis of PID, treatment regimens, pelvic abscess, and lastly, chronic PID. As you see in this picture, this is the uterus, this is the cervix, this is the external os, and this is the internal os. This is the fallopian tubes on both sides, and this is the ovaries. PID, pelvic inflammatory disease, affecting the upper genital tract and the ovaries. What is the landmark here, or the starting point from the internal os upwards? So, including the endometrium, including the fallopian tubes, including the broad ligament and the parametrium, including the ovary. Okay, so all structures above the internal os included in PID. Let us start with the definition. PID is defined as acute upper genital tract infections that involve endometrium causing endometritis, as in the picture, parametrium causing parametritis, the parametrium here in the broad ligament, fallopian tubes causing salpingitis, this is the fallopian tube, ovaries causing ophritis, this is the ovaries, and pelvic peritoneum causing peritonitis. What about the prevalence? Examination survey in 2013 to 2014 data, 4.54% of women 18 to 44 years of age in the United States reported a history of PID. And it is said that more than 1 million cases diagnosed each year of PID in the United States. Approximately 15% of untreated chlamydial infections progress to PID. This percentage may be higher with gonococcal infections. This is the pathway of the ascending infection. The infection ascends from the cervix during cervicitis, reaching the endometrium causing endometritis, which go to the fallopian tubes causing salpingitis and oophritis to the ovaries, and they may be complicated to tube ovarian abscess. Also, pelvic peritoneum becomes affected, causing peritonitis. So what about the risk factors? The most important one is sexually transmitted infections. All sexually transmitted disease is important, especially the chlamydia and the Neisseria gonorrhea. There are certain factors affecting the infection or increase the risk of infection, like the age, with the young age 15 to 20 years, because increased sexual activity in young age in certain countries. Race, in black races due to low socioeconomic state, douching because of pressure in the vagina forcing material up through the cervix, cigarette smoking because it decreased the immune system, previous episodes of acute salpingitis, damaged tube, make it susceptible to altered defense mechanism, sexual intercourse and the multiple sexual partners, especially in young age, risk of meeting male with sexually transmitted disease, use of ID among women with increased risk of sexually transmitted infection. The second important risk factor is postpartum. which is a very important period after delivery, the risk of infection is high. The third one is post-operative, as following gynecologic surgery. What about the microbiology? Infective organisms are sexually transmitted like chlamydia and Neisseria gonorrhea, endogenous aerobic streptococci, E. coli, Haemophilus, anaerobes like bacteroids, Peptostreptococcus, bacterial vaginosis, Actinomyces israeli, Mycobacterium, tuberculosis, and bovis. What about the pathology? There is mild PID, moderate PID, severe PID, and special entity which is called Fitz-Hugh-Curtis syndrome. Let us start with mild PID. In mild PID, as in the picture here, there is the serosal surface of the fallopian tube appear red and hyperemic. Tubes are edematous but freely mobile with patent abdominal ostia, so the tubal ostia is still open. The exudate may be sticky, virulent on the serosal surface of the pelvic organ and exuding from the fimbrial end of the tube. In moderate PID, inflammation, as in the picture, and the edema of the fallopian tube is more pronounced. Tubal mobility becomes limited. Patchy fibrin deposits are seen in the serosal surface, and loose adhesions may form between pelvic and abdominal viscera, like these adhesions. The distal end of the fallopian tube often appear phimotic, and the tubes may not be patent. So here the tubes may be not patent, and there is limited mobility, and there is edema and some filmy adhesions. What about the severe PID? As in this picture, also occlusion of the tubal ostia as a result of fimbria sticking together, resulting in hydrosalpinx and biosalpinx. Marked distortion of the pelvic anatomy, as you see in the picture. Pelvic peritoneum is severely damaged and the pelvic organs become adherent, resulting in formation of complex inflammatory mass, like these adhesions to the pelvic organ, to the omentum and the colon, the fallopian tube and the uterus. If the infectious process has not been sealed off in the fallopian tube, a tubulo-ovarian abscess may develop. And this is a very important case. Again, in pathology, also laparoscopy can visualize violin string adhesions characteristic of Fitz-Hugh-Curtis syndrome due to perihepatitis. As you see in the picture, this is the adhesions, violin string adhesions. This is the liver, and this is parietal peritone, and this is the adhesions, as you see it everywhere. This is characteristic for sexually transmitted disease, chlamydial trachomatis, and the Neisseria gonorrhea, and can be diagnosed during laparoscopy. The patient complains of right hypochondrial pain, fever, nausea, vomiting, associated with other symptoms of the sexual transmitted disease. What about the prognosis of pelvic inflammatory disease? Subsides if treated properly, or become chronic if inadequate treatment was given, leading to hydrosalpinx, biosalpinx, tubal obstruction, peritoneal adhesions, and lastly may cause, as is in this picture, infertility, ectopic pregnancy, chronic pelvic pain, and this is very important sequelae to PID. Or the most bad prognosis, which is mortality, may occur due to ruptured tubal abscess and septic shock. What about the clinical picture? Severe pain and tenderness in the lower abdomen, fever, malaise, vomiting, tachycardia, offensive vaginal discharge, irregular vaginal bleeding, bilateral adnexal tenderness, cervical mobility tenderness, tube ovarian mass. What about the diagnosis? Diagnosis first depend on clinical picture. Certain criteria are used to diagnose PID by Center of Disease Control. And as we see in this table, I have minimum criteria, additional criteria, definitive criteria. What about the minimum criteria? Minimum criteria include lower abdominal tenderness on palpation, bilateral adnexal tenderness, cervical motion tenderness, no other established cause for these signs, negative pregnancy test because there is differential diagnosis with ectopic pregnancy, which is also associated with lower abdominal pain and tenderness and tender mobility of the cervix. Okay, let us go to the additional criteria. Oral temperature more than 38.3 degree, abnormal cervical and vaginal discharge, elevated ESR, elevated C-reactive protein, abundant white BCs on saline microscopy of vaginal secretions, lab documentation of cervical infection with Neisseria gonorrhea or Chlamydia trachomatis. The last item, which is definitive criteria, conclusive one, like endometrial biopsy with histopathology, giving me an evidence of endometritis, or transvaginal sonography or Doppler ultrasound or MRI with thickened fluid filled tubes, free pelvic fluid, tube ovarian complex, or hyperemia, hypervascularity of the tube by Doppler. Laparoscopic abnormalities consistent with PID, as we mentioned before. So all these criteria, minimum criteria, additional criteria, definitive criteria, help me to diagnose pelvic inflammatory disease. Next, lab investigation. Lab investigation aiming to detect organism or evidence of their antibodies, like gram stain and cervical culture for gonococci or high vaginal swab for Trichomonas vaginalis, gram stain for bacterial vaginosis, ELISA or culture from the cervix for chlamydia, urethral, rectal, or oral cultures for gonococci, serological tests for hepatitis B, C, syphilis, HIV, as the patient with one sexually transmitted disease is at risk for other infection. And this is very important. What about the laparoscopic diagnosis, which is definitive in diagnosis or gold standard? Pronounced hyperemia of the tubal surface, edema of the tubal wall, sticky exudate on the tubal surface and from tubal ends when patent. What about the differential diagnosis of pelvic inflammatory disease? Gynecologic, like ectopic pregnancy, and we can exclude by doing serum beta HCG and by doing transvaginal ultrasonography and using discrimination zone. Torsion or ruptured ovarian cyst or endometriosis or complicated endometrioma or Shacklet cyst. GIT, like appendicitis, diverticulitis, urinary tract infection like cystitis or pyelonephritis. So, differential diagnosis including items from gynecology or GIT or urinary tract. What about treatment of PID? The main principle for treatment of PID is that the goal of therapy in uncomplicated acute salpingitis is relief of acute symptoms, eradication of current infection, and the prevention of infertility, prevention of ectopic pregnancy, and the prevention of tube-ovarian abscess. The other goal of therapy in salpingitis complicated by abscess is preservation of life because it is life-threatening condition, prevention of septic complication and septicemia, life-threatening condition also. Treatment of PID, including general measures and antibiotic regimens. General measures like rest in fowler position, light diet with free fluid, sedatives and analgesics, give antibiotics. As PID is polymicrobial, antibiotics should cover chlamydia, Neisseria gonorrhea, anaerobes, gram-positive and gram-negative aerobes. So I need a combination of antibiotic to cover all these. So the regimen will depend on the severity, and it may be an outpatient treatment or inpatient regimen. Outpatient regimen, if symptoms and signs are mild, I can give ceftriaxone 250 milligram intramuscular single dose plus doxycycline 100 milligram twice daily for 14 days plus metronidazole 500 milligram twice daily for 14 days. What about the inpatient regimen? What are the criteria to hospitalize the patient? Diagnosis is uncertain. Suspected pelvic abscess, suspected pregnancy, patient is using IUD, temperature is more than 38, severe illness, nausea and vomiting, adolescent patient, failure to respond to oral antibiotic within 48 hours, also intolerant patient who cannot do follow-up in outpatient treatment. Okay, this is an example for parenteral treatment regimen. Cefotitan 2 gram IV every 12 hours till 24 to 48 hours after relief of the symptoms. Then continue by oral regimen. Another example, cefoxitin 2 gram intravenous every 6 hours, also till symptoms relieved by 24 to 48 hours. Then continue oral treatment. CDC recommend certain regimens, different regimens, A, B, C. We can take any one of them, any line of them. Other management consideration. Something very important. To minimize disease transmission, women should be instructed to abstain from sexual intercourse until therapy is completed. Symptoms have resolved and sex partners have been adequately treated. It's very important to treat the sex partner. Okay, what about the clinical recommendation and the grade of evidence? According to guidelines, the diagnosis of PID should be made clinically in absence of other obvious causes in an at-risk woman with unexplained pelvic pain and cervical motion, uterine or adnexal tenderness. Grade C, evidence. Empiric antibiotic treatment should be offered at the time of presentation to patients with PID symptoms. Grade C, evidence. Women with mild to moderate PID may be treated in an outpatient setting without increased risk of sequelae. Grade B, evidence. Patient delivered or expedited partner therapy for sexually transmitted infections should be offered where legal to decrease rates of reinfection. Grade B, evidence. Annual screening for chlamydia and gonorrhea is recommended in all sexually active women younger than 25 years and any women who are at increased risk of sexually transmitted infections. Grade B evidence. Pelvic abscess. What about it? Maybe tubo-ovarian abscess, which is communication between biosalpinx, which is fallopian tube distended with pus, and the ovarian abscess. Or central pelvic abscess, in which there is pelvic peritonitis, pus collection, and Douglas pouch, roofed by adherent intestine and omentum. And as you see in this picture, this is an example of central pelvic abscess. This is the pus in the Douglas pouch, dissecting through the rectovaginal space and through chaldosynthesis by a needle connected to a syringe. We can aspirate the pus. And in the other picture, another example of tube ovarian abscess, which is not deep like the central pelvic abscess. Tube ovarian abscess, here I can reach it through laparotomy, not through the vagina. Okay, this is a tube ovarian abscess. Pelvic abscess can be divided according to the mode of infection into primary or secondary. Primary due to ascending infection without predisposing factor, I mean without surgery, without trauma or pregnancy. While secondary, following pregnancy, post-abortive infection, puerperal infection, infected complicated ectopic pregnancy, or direct extension from nearby organ like appendicitis or diverticulitis, or following surgery, example cuff abscess of prostatectomy. What about the clinical presentation? Uncomplicated tube ovarian abscess. Patient appears ill with temperature elevated, abdominal distension, and direct and rebound tenderness in the lower abdominal quadrant. Pelvic examination is extremely painful with tender cervical mobility. An irregular tender fixed inflammatory mass may be felt on one or both sides of the pelvis, like these masses, bilateral adnexal masses. Bilateral tube ovarian abscess. Ruptured tube ovarian abscess, which is more dangerous. Symptoms include acute, progressive, sudden pelvic pain, which is so severe that the patient can accurately identify the time and the place of its occurrence. Symptoms and signs of pelvic abscess include the patient is dehydrated, with severe illness, with abdominal distension, absent intestinal sound sometimes, pelvic mass is felt in 50% of cases, fever, tachycardia, leukocytosis, chaldosynthesis reveal purulent material, signs of generalized peritonitis with shifting dullness. Management of pelvic abscess, of course, need drainage through posterior colpotomy to drain the abscess. After hospitalization, of course, and under anesthesia. And under umbrella of broad-spectrum antibiotics covering the polymicrobial infection. Chronic pelvic inflammatory disease means chronic infection in the upper genital tract or internal genital organs. The damaged organs also become vulnerable to infection by other bacteria, so that chronic PID often involves multiple bacteria. As you see in the picture, this is laparoscopy. This is the normal laparoscopy, how it looks, and this is the laparoscopy of chronic pelvic inflammatory disease, and you can see the hydrosalpinx and the biosalpinx and the adhesions and distortion of the anatomy. What are the pathologic types of chronic PID? Hydrosalpinx, the tubes are plugged at their terminal end with accumulation of serous exudate within the tubal lumen causing distension. As in this picture, this is hydrosalpinx. The tube is closed at its end and the tube is filled with fluid. And this is by ultrasound. This tubular lesion is hydrosalpinx. Biosalpinx, accumulation of purulent exudate within the tubal lumen. Interstitial salpingophritis, diffuse or localized and nodular, affecting areas of the tube with healthy areas in between. Number 4, tube ovarian cyst, which is hydrosalpinx communicate with ovarian cyst, or tube ovarian abscess, biosalpinx communicate with ovarian abscess, like this picture, tube ovarian abscess. Pelvic adhesions, frequently massive, between pelvic organs, including the uterus, fallopian tubes, ovaries, bowel, and the pelvic side wall, as these adhesions with the bowel and with the tube, with the peritoneum, with the uterus, as in this picture also. This is adhesions, all these are adhesions. What about the clinical picture of chronic PID? General malaise and fatigue, chronic lower abdominal pain and backache, intermittent vaginal discharge, deep dyspareunia and dysmenorrhea, heavy periods or intermenstrual bleeding, infertility, bowel symptoms including colic, constipation, lower abdominal pain and pelvic tenderness. The uterus is bulky and tender. Intermittently, the chronic infection is complicated by acute episodes characterized by fever and severe pain. Differential diagnosis of chronic PID include uterine fibroid, pelvic endometriosis, chronic disturbed ectopic pregnancy, which is very important to differentiate it, as in this picture, this is an ectopic pregnancy. Serum beta HCG is diagnostic. Chronic appendicitis, ovarian tumor, broad ligament tumor, TB of pelvic organ. Of course, I can use different tools for differentiation using transvaginal ultrasound and abdominal ultrasound, and using some markers to detect the lesion. Diagnosis of hydrosalpinx. As you see in this picture, this is hydrosalpinx. The tube is distended, as you see here. Also, the tube is distended, tubular structure, S-shaped or C-shaped. Transvaginal ultrasound recognize hydrosalpinx by its location separate from the ovary, its tubular appearance, C-shaped or S-shaped, as you see here in the picture, fluid-filled structure, and occasional longitudinal folds in the ampullary portion of the fallopian tube. This is characteristic. Also, you can see indentation on both sides, what is called waist sign. Indentation on each side, indentation on each side is called waist sign. Pseudohysterosalpingography is a useful tool also in diagnosis of hydrosalpinx. You inject saline inside the uterine cavity through Foley's catheter, and you do transvaginal ultrasound at the same moment. And of course, you fix the catheter in place. Also diagnostic because the tube will be distended and can be seen by the transvaginal sonography. Laparoscopy, gold standard for diagnosis. Salpingoscopy or falloposcopy also can be used for diagnosis. The treatment of chronic salpingitis include medical treatment and surgical treatment. Medical treatment: rest in fowler position, as you see in this picture, proper diet and vitamins, pelvic heat, example, short wave therapy, long therapy, long course of antibiotic, broad spectrum antibiotics, anti-inflammatory drugs. Surgical treatment include conservative surgical treatment, like if the patient wanted to be pregnant, if the patient is still young, if the condition is not that severe and the tube can be managed, we can go through the conservative treatment. So it depends on the age of the patient, completed her family or not, her desire for fertility. We can do salpingolysis, adhesolysis for adhesion. We can do salpingostomy for hydrosalpinx, like this one. We open the distended tube by incision like that. This is called salpingostomy, to drain the fluid inside. Or we can do salpingectomy, as in this picture, we excise the fallopian tube. Or we can do salpingo-oophorectomy. We can remove the tube and the adjacent ovary also, if affected. Salpingo-oophorectomy. So I may need that because the infection badly damages the tube and the ovary. Also, I can do transvaginal ultrasound guided aspiration of tube ovarian abscess under cover of antimicrobial therapy. Also, I can do cervical dilatation in case of biometria under umbrella of antibiotics, also to drain the pus inside the uterine cavity in case of biometria. All these operations is called conservative surgery. What about radical one? If the patient completed her family and the uterus or tubes or ovaries are badly damaged, or the condition is life-threatening, I may reach up to hysterectomy and bilateral salpingo-oophorectomy, or I may do bilateral salpingo-oophorectomy without hysterectomy if not needed, or I may do radical surgical operation by removing the uterus, tubes, and the ovaries. Lastly, in this picture, I want to let you to see the hydrosalpinx here. This is a fimbrial phimosis. We can reconstruct the fimbria doing fimbroplasty, as in this picture, to make it open again and to avoid to be sticky or adherent again or become phimotic again. This is one of the lines for treatment of hydrosalpinx. This is the adhesions with the ovary and uterus and with the fallopian tubes. We can do adhesolysis, cutting these adhesions, laparoscopic adhesolysis, as a line of treatment also. So we can separate it like in this picture. We separate the ovary from the tube and from the uterus, and we did fimbrioplasty, repair of the fimbrial end, which was closed by phimosis. So all these are lines of treatment can be done via laparoscopy. Also, in case the patient, if she wanted to do ICSI and she can tolerate to do it, we can do, in case of severe hydrosalpinx or in case of biosalpinx, we can do tubal disconnection of the fallopian tube from the uterus, cutting the connection with the fallopian tube with the uterus, so long as the patient will do ICSI. So in case of ART, plan for ART, I can do tubal disconnection in severe hydrosalpinx and biosalpinx. Why? Because there is evidence that the success rate of pregnancy in ART increase if we did tubal disconnection, because there is suspicious that the fluid inside the fallopian tubes is embryotoxic, prevent implantation, and prevent success of ICSI. So, in case of planning for ICSI, I can do tubal disconnection. This is another line of treatment also to increase success rate of fertility. If the patient is not going to do ICSI or cannot, or uh, refusing to do ICSI, or cannot tolerate the financial uh, effort, so I can try to do conservative surgery like fembryoplasty or salpingostomy and also adhesolysis. Thank you. I'm Dr. Ala Musbah, Professor of Obstetrics and Gynecology, Faculty of Medicine, Mansoura University.